So thank you for your invitation. I'm going to talk to you about some advances in the therapeutics on the irritable bowel syndrome. This is a very important symptom because functional diseases are all the time uh, in the most important part of our consult everywhere in the world. So we need to know what to do and how to do things in order to get our patients good. So we'll talk about these several things here. First, food, how to manage food for these kind of patients. Some group of different kind of drugs, some old, some new, and finally some new developments on psychotherapy and fecal transplant. Let's start with diet. It is supposed that IBS is caused by some dysfunction in how we process food. So there has been a lot of interest in diets and change in diets. And the last one was this one, the FODMAP, fermentable oligosaccharides, disaccharides, monosaccharides, and polyols that are supposed to increase the gas and make really problems for the people. So the FODMAP diet is trying to decrease or even eliminate these FODMAPs and in that way increase GI water secretion and try to quit triggering of the mirror symptoms. There's a couple of systematic reviews on this. This was the one of 2019 from the group of Ford of the UK. And you can see there's some effect. Low FODMAPs are better than high FODMAPs. But you can see that the effect is not very big, but it exists. So this can work if you just lower the FODMAPs compared with high FODMAP diets and also with usual diets. So FODMAP seems to work quite well. This is a more recent one. This is from this year, also from the group of Ford of the UK. This was a network meta-analysis, and it is showing how different diets may work, or actually how different diets does not work. Only the FODMAP diet works. Again, the confidence interval is not very good, but it really works. And all the other diets, high FODMAP, another advice, the NICE diet that is also quite well known, does not work. So when we go about diets, FODMAP is the only one that can be used. How about fiber? Fiber is supposed to help, but not being absorbed, not being digested, and usually is supposed to bring water into the stool and help with constipation. There are two types of fiber: the soluble fiber, psyllium, oat bran, barley, beans, usually, and the insoluble one, wheat bran and whole grains. And this is important because there's a difference between how the fibers work. This is not that new. This is from 2014, also from the group of the UK with Evan Quigley and also Paul Moyeli from the McMaster. And you can see bran, who is an insoluble diet, does not work. The confidence interval is not good enough. And Ispagula, who is a soluble one, it does work. Also, in the same way as FODMAPs, the effect is not very large, but it is there and it works. So soluble fiber is what is working. Another one, soluble fiber, again, it is working. More than one here, so it works. There are several studies on this. So we have some other thing that works, that is soluble fiber. Antispasmodics are the first kind of drugs that are used everywhere around the world. They are very old. You have the dicloclomine, iosamine, iosine and the older ones, pinavirin, otilonium, trimebutine. So there is no really new information here. The publications are quite old. The methodology is poor. They were small size because that's how the studies can be done at that time. The new ACG guideline recommends against this. They say that this guideline is from January of this year, and they say no, we shouldn't use this because this does not work, and because the publications are old, are poor, are not good enough. However, when you see the data, yes, it's very old. Look at this, pinaburium, 81, 77, 87, is very old. It works a little bit, just like FODMAP, just like fiber. So probably we may consider this also trimibutene in some scenarios, in some patients of the line here also very old. So you can say the information is not very good, the confidence is not very good, but they do seem to work in some patients. Another very old thing is peppermint oil. It's menta piperita. We don't know what they do. We know they can block calcium channels and produce a smooth muscle relaxation. Some people say there's antimicrobial properties, also anti-inflammatory, that is not really proven yet. And they seem to work quite well. In the global assessment of the IBS and also for abdominal pain. So in both of them, they are good. The resource bias is quite well. The quality is quite good for this kind of studies. And this is probably what works best, peppermint oil. Not difficult to find anywhere. Probiotics are really the fashion right now. We are having a lot of studies talking about probiotics, but there are two important problems. There's a lot of probiotics, very different single uses of probiotics, and also there's a lot of different combinations. So it's very difficult to say what works, what really works here. These are the most common known: Lactobacillus, Saccharomyces, and Bifidobacterium. None of them seem to work. This is a systematic review from the 2018. This is a larger one that compares, it compares the same: Saccharomyces, Bifidobacterium, Lactobacillus. Lactobacillus seems to work a little bit, but not too much. And also in this one from Russia that was published last year, they also tried a lot of different combinations. None of them work. So probably probiotics are still not ripe enough to use. In constipation, we know about polyethylene glycol. It has been used a long time. It's now the standard from colonoscopy preparation, and it works very well as laxative. But there have been just two studies, randomized controlled trials, and it doesn't work. Not for abdominal pain, not for rectal tone or sensitivity that is urge or pain to defecate. So this is a very good laxative. It's not very good when you talk about symptoms of IBS. There's no enough studies to do a systematic review. The guideline of the ACG have just summarized this. Now the newer drugs that are quite important, lubiprostone is quite known because it works very well in IBS with constipation. Not enough information yet, but the information is available, is of high quality, and it works. Also, not a lot. You can see the confidence interval, it goes up to 5% of working from the 13%. But it's working. The analysis says this works, but look how. 17, almost 18% in the people receiving lubiprostone versus 10% of the people receiving placebo. So it's not a lot of working, but it does work. You should consider the price that you're taking and the time. Usually this starts working after 2 months of continuous use, not before. Another of the newer drugs, the 1L8 cyclase activators, also for constipation, linaclotide, plecanatide, tenapanor, that is newer. This is another network systematic review. As you can see, they all seem to work. Linaclotide, tenapanor, lubiprostone, we've already seen, plecanatide. So this can also be a good adding. Also, you have to consider always the price of these newer things. This is old and new. Tegaserot was very well known about a decade ago, 10 years ago. It was very good when it appeared. It seems to be quite impressive. And if you remember the numbers, the numbers were quite good. But after a while, there appears a lot of cardiovascular risk problems, and they withdraw it. So now it's coming again, but with a lot of restrictions, only for women younger than 65 years old, with one or none cardiovascular risk factors, and it's also is tried as a second-line treatment. So something doesn't work, we've already tried something. Well, yeah, now it's time to use tigaserot, but only in this very restricted group of people. There's a preliminary report on cardiovascular risk. There's a difference. The risk is larger in the people who use tigaserot, but you can say it is larger, but it is very little, 0.11%. And the risk in the general population is 0.01%. So this is very old. This is from 2008 and 2009. Look at the dates, because this is an old drug that has come along again, and it's working. So this is very good, and this can be used again, but you have to be very careful with what kind of patient you are giving things. Antibiotics, the rifaximin is the antibiotic we use usually for anything related to the intestinal tract. It has something to do with the probiotics, because the problem probably is that the microbiome is abnormal, and the antibiotic treatment will recover the flora. What do we know? There are some studies, you can see, quite well done, and it works. It has some effect that we can use. So rifaximin is one of the other drugs, the only antibiotic that you can use for IBS. Another newer drug, a Lossatron, a 5-HT3 antagonist, and this is one of that works for diarrhea. Most of the treatment is for constipation, some for pain also. They are little for diarrhea. Also, they work. These studies were from quite old. The systematic review from 2017, but it shows that it is still working. So if you have a patient with diarrhea, aldosterone is something that you can use. There's not much about opioid antagonists. Elutazolin is one of the only one that is really have studies. Seems to work a little bit for IBS with diarrhea. Antidepressants have been quite well used. They work really well when you have pain, because they improve the norepinephrine and pioneering receptors that improve both central and visceral pain. And there are some information specific from tricyclic antidepressants, and they seem to work well. What you see, we don't have a lot of bigger or larger effects, but the effect is there and is working. There are some other things like the SSRIs. They don't seem to work as well as the tricyclic antidepressants. The problem here is sometimes you have some adverse events, and sometimes it's very important in some patients, but it can work very well if you have patients who have a lot of pain. There's a lot of studies. This is a newer systematic review from 2019, also from the fourth group from the UK, and you can see it's still working. And there's a lot more information now. The prior from 2015 just have 5 studies. Now there are 12, and it keeps working. So this is a safe bet also. Finally, psychotherapy is a lot of different things. So it's not just one intervention, but it's a cognitive behavior, gut-directed therapy. You can see different forms also. This is a group CBT, the cognitive behavior treatment, also via telephone, the stress management, the relaxation, hypnotherapy. Some of them seem to work quite well. Some of them not good enough. This is a systematic network with analysis from 2020. And you can see the first 3 or 4 ones are quite good. Also till here, different forms of CBT. This is important, for example, because in these COVID times, when you can do a lot through the video or telephone, this works in face-to-face with minimal contact by a telephone, so this can work. Some other things does not work that well. Maybe we need more studies in most of these. And well, there are several ways of psychotherapy that can work and should be addressed. Fecal transplant has been for about 5 years or a little more, the best approved treatment from Clostridium difficile colitis. It works. The rationale is they change the gut microbiome because you are putting another people gut microbiome in there, and it really works, and it is well known and recognized to work in this kind of colitis. Since we talk about microbiome in IBS, it should be rational to try it because we believe IBS also is an alteration of gut microbiome. Problem is there are different ways of treatment: oral capsules, colonoscopy, and nasogenital tube. And they are not quite well. This seems to work a little bit, but there are only 2 studies by oral capsules. This is not. This is not working. This is working here. Colonoscopy, quite marginally, only 2 studies. This is not working also by the tube. And if you join the 3 ways, it doesn't work. So at this time, fecal transplant is not really a good option, but it may have some role when we have more studies. This is in the 2021 guideline from ACE, and also in this expanded review from 2019. This is the newer things for randomized controlled trials. Still not work enough. Not enough to work. Look at the confidence interval. This is not working. So we have some little things that work. Diet, limited trials of FODMAP. We have to consider here how difficult it's going to be for the patient to follow this kind of restrictive diet. Soluble fiber is good. It's not difficult to find. Peppermint oil also. Polyethylene glycol in some patients with constipation is not really that good. Lubiprostone, lanaclotide, tegaserot, Lossatron, they all work. Eluxadaline, yes. Tricyclic antidepressants and rifaximin. This works. What doesn't work? Any other kind of diet, gluten-free diet, and all the diets we've seen that does not work. Insoluble fibers, wheat bran is not good for people with IBS. It produces gas. It ferments in the colon. And the spasmodics, we have not enough studies, and the studies are quite old. We may try them with caution. No role yet for probiotics or fecal transplant. These are still in the investigation, and the jury is not out yet. So this is all I have to share with you. Do you have any questions?